For lecture 4, the last lecture of week 7, I'm going to talk a little bit about hormone influence on the kidneys and micturition reflex, which is urination. So micturition is urination, and basically urination is a reflex followed by a voluntary action. So there's a reflex that responds to the stretch receptors as the bladder fills with urine. As the bladder fills with urine, the stretch receptors are stimulated. That sends an impulse to the reflex center, which is going to be in our spinal cord. And with a reflex, if you're not familiar with reflexes, if you haven't had 215, basically a reflex is an action, like a receptor, stimulus, control center action pathway, but it doesn't go to the brain. The spinal cord handles it for integration. So basically what happens is the detrusor muscle contracts. So that's the muscle that makes up the bladder. That's going to contract. The internal sphincter is going to relax, and that's all part of the reflex. That's all involuntary. And then the voluntary part is you relaxing your external urethral sphincter when you're ready to urinate. The reflex center is mostly in the sacral spinal cord. There's some integration with the pons and hypothalamus, but most of it's going to be here. So basically, again, the bladder distends because it fills, right? So it gets saggier, kind of lower, stimulates stretch receptors. There's a parasympathetic stimulation to contract the detrusor muscle and relax the internal urethral sphincter. That gives you your urgency, and then you can control whether or not you're about to urinate. This is a really complicated picture for something very simple, but basically here's your full bladder. It has stretched. That will send a message to, to the spinal cord, telling the detrusor muscle to contract. And that's going to be here, right here. That's step 3. That's the involuntary here. And then the detrusor muscle will contract, and then the internal sphincter will relax. For voluntary control, that's where the brain comes in. So that's not the reflex anymore. The reflex is the involuntary part. The voluntary part is actually conscious here to the brain. So pons is going to receive that signal, and basically that's going to tell the detrusor muscle to continue to contract and internal sphincter to relax. And then ultimately your brain will tell your external sphincter to relax, and then you can urinate. So most of it is reflex. There is some conscious voluntary control going. But again, this is a very complicated picture for something pretty simple. So your bladder can fill with about 600 mils prior to it being painful. You start to get the urge after your bladder has about 150 mils in there, uncomfortable about 300, and then you are going to want to urinate. The more full your bladder gets, the stronger those detrusor muscle contractions are going to get. And then once you actually urinate, the reflex stops and the voluntary part takes over. And so that reflex of the detrusor muscle contracting and the internal sphincter relaxing, and that urge, that goes away, and then you're able to relieve yourself voluntarily. So normal composition of urine, it's straw colored, usually distinctive odor, nothing crazy, but the specific gravity is going to be like the density of urine. So the density of water is 1. Notice how the specific gravity density of urine is a little bit higher than 1. That's because of the solute presence. So we're going to have more solutes than just regular distilled water, obviously, in your urine. This is going to be how many solutes you have per liter. And so it can be anywhere from 50 to 1200, just depending on how many solutes are excreted. The pH is slightly acidic at 6 because of those hydrogen ions. Urine is made up mostly of water, a little bit of solutes. Here's the solutes that we've talked about that could be present in your urine. And we urinate about 1 to 2 liters per day on average. So remember that the distal convoluted tubule responds to the renal hormones. And so that's why in that distal tubule, you have permeability to still sodium and water, because those things are very prime players when it comes to a lot of these hormones. So the renin-angiotensin-aldosterone syndrome system. This is when your blood pressure is low. So if your blood pressure is too low, what your body can do is release renin, tell your kidneys to release renin, and that converts something called angiotensinogen, which comes from your liver, into angiotensin 1. Renin is an enzyme, so it's going to convert angiotensinogen into angiotensin 1. Then you have this enzyme called ACE in your lungs that is going to be released and then convert angiotensin 1 to angiotensin 2. Angiotensin 2 is going to be our active player here. So again, your cells in your nephron and your kidney release renin. It's all stimulated though by your baroreceptors, which are pressure receptors, usually in the aorta or the carotids. They're detecting that blood pressure that's happening systemically. And then if blood pressure is too low, if they're not sensing enough pressure, then they will tell the kidneys to release renin. That will stimulate the sympathetic nervous system. It will also reabsorb a lot of sodium and chloride. So decreasing the amount that's filtered out in the filtrate, reabsorbing that into the bloodstream. If we reabsorb sodium and chloride into the bloodstream, water will follow. That will increase our volume of blood and then therefore increase the pressure and correct that low blood pressure. Angiotensin 2, let's talk a little bit more about what that does. So specifically, angiotensin 2 is a vasoconstrictor. So we know that if we vasoconstrict, we're going to raise our blood pressure. That's good, right? We're trying to correct a low blood pressure. So it's going to constrict the afferent arteriole here, and that will decrease our GFR, and then also constrict the efferent arteriole to keep the fluid in here for a longer period of time so that more filtration can happen. Remember that the reason for this is because our blood pressure is too low right now. So what's the benefit of constricting the afferent and efferent arteriole? Your GFR loss is minimized. So when the systemic pressure is low, we're maintaining the GFR in here. Let's see here. Recall autoregulation, however, so this angiotensin 2 is a vasoconstrictor, so it's going to constrict the afferent arteriole, but remember that autoregulation would then dilate the afferent arteriole to allow more blood to go into it. But essentially the point of the angiotensin 2 is to conserve whatever we have in here and to minimize GFR loss due to the low blood pressure until that's corrected. Also, angiotensin 2 stimulates aldosterone secretion, and if you can recall, aldosterone promotes the reabsorption of sodium in the distal tubule, and then water will follow. That will decrease our urine output, so that's a good thing, right? If you have low blood pressure, we want our urine output to be decreased so that we're reabsorbing that water to contribute to blood volume and therefore blood pressure. And then it's also going to stimulate ADH, which is vasopressin, which also tells the kidneys to retain water. And then also it's going to tell your hypothalamus in your brain that you are thirsty and to drink. Remember that there's some cardiac hormones as well. So there's ANP and BNP. Basically, these are during high blood pressure. So what these are going to do is promote sodium secretion, and then water will follow, and that will decrease blood volume and therefore decrease blood pressure and increase urination volume. And then they're also going to inhibit the renin-angiotensin system and the ADH. So basically they're stopping this, and then the opposite effect will happen. So clinical correlation for you, ACE inhibitors. So these are types of blood pressure medication for the treatment of some hypertension. Basically, hypertension would be one cause, might be the increased renin and angiotensin 2 release. So remember that those things are released in response to low blood pressure. But if those things are released in excess, now we're going to have too high of a blood pressure because now we've overcorrected. And so what we can do is give somebody ACE inhibitors, and what that's going to do is shut off that ACE. And if we stop ACE right here, then we never have that conversion of angiotensin 1 into angiotensin 2. And so that inhibits our blood pressure from even getting higher. So some people have the excess release of renin and angiotensin 2, which is going to increase your blood pressure beyond normal. And so we can give them ACE inhibitors that will inhibit the creation of angiotensin 2. One example would be lisinopril, if anybody's ever heard of that one. All right, so that one was short and sweet. That wraps up the urinary system for this week. And please let me know if you guys have any questions.